crowd that easily, but yeah, I think if we go ahead and start, so we can all go out and do our work. So I love grand rounds. I've always loved grand rounds. Ever since I was a medical student, I was one of those people that no matter what rotation I was on, I made the effort to get to grand rounds for a number of different reasons. I know that my predecessor here in this position liked grand rounds too. He specifically liked it because he viewed it as a way for all of us to get together at least once a week as a department. My reasons for liking grand rounds were very different and extraordinarily selfish. I really liked having the hour where I could sit down and listen to somebody explain something very, very well. I think about all those times, and maybe you do too, all those times when you see an article in a journal and you take it out or whatever and say, gee whiz, this is interesting. They found a connection between anosmia and dementia. I should read that sometime. And that article sits there, it gets curled pages, coffee gets on it. Or if you downloaded it, it ends up in your file of quote unquote interesting articles that you actually never get to. So if you come to grand rounds, sometimes somebody will just give that talk. And for an hour, you can learn about whatever that was in a relatively painless fashion. But the other thing that grand rounds is good for is to let you know what else is happening in other fields that you haven't been able to keep up with. When I think about myself, so I do mineral metabolism and phosphate transport, and I think that we're making huge advances, and I think it's very exciting. And I guess sometimes I just forget that this is happening in every single other field. So when I sit down and I hear somebody get up and talk about heart failure with preserved ejection fraction, and I think to myself, oh my God, you know, when I was learning heart failure, didn't that mean that your heart didn't work? So how could you have heart failure and still have a preserved ejection fraction? And God knows now in cardiology, they've divided up acute MI into so many different subtypes that I can't even count them now. The only way I can even hope to try to keep up with that is to go to grand rounds. So grand rounds is exhilarating, and I don't know why this keeps doing this. Grand rounds is exhilarating because somebody's saying do something with this. Okay, so thank you. Okay, so grand rounds is exhilarating. It teaches me something new every week. It's also very humbling, because I learned that there's absolutely no way on earth I can keep up with everything, and I'm a fool if I think that I can. So today, what I'm going to do is, I have no slides. I inadvertently left my notes in the car, so I'm just going to talk to you guys about something that's very important to me, and that is the Department of Medicine, where it is, how it got here, and of course, most importantly, the way forward from here. And I do that in the context of three things that I like a lot. So you've heard the first one, which is grand rounds. What is the second one? I love listening to NPR. I love listening to NPR. I'm a complete NPR addict. I listen to it in the morning. I listen to it in the evening on the way home. I love Terry Gross. I love Mary Louise Kelly. I love all of these people that get on. I even listen to things that I would never think that I would want to listen to, like economics. I know what the FTSE is, and I never in a million years would have thought about reading about that or picking that up. I especially like some of the special commentators that come on, and one of them is a guy by the name of Shankar Vedantam. Now, some of you guys may be familiar with him. He is, I guess, a psychologist. I actually don't know what he is, but he comes on and he gives commentary on human behavior and human social interactions. And actually, I didn't realize it, but until earlier this year, but he's got his own radio program on Saturday that's called Hidden Brain. I have heard a piece of that program once in my life, doing what most of us do on Saturday, which is driving around, getting your errands done. So somewhere between the bank and the grocery store, I heard this guy was interviewing another social scientist who talked about tribes, the people that we live with, the people that we work with, and of the little piece of this, only one little bit of that stuck. They had done some research on what is the ideal size of a group of individuals, because human beings are very social, and they had come up with the number of 150. And that stuck with me. 150 people. I guess you can only have 150 BFFs. And then after that, people start drifting off into little cliques and forming their own groups. The next thing you know, you have a whole other set of people of 150. And it keeps going like that. Well, for me, this posed a real problem, because I figure that my role as the interim chair is to bring together a group of people who have very diverse interests and very diverse aims in life into a cohesive whole. Now, I asked Sherry Hurdle to get together, okay, how many people are in the Department of Medicine? Okay, over 200 faculty, staff, UofL staff, ULP staff, trainees, students, PhDs, graduate students. Altogether, the number was close to 800. 800. And I thought, oh my God, if 150 is our optimal size, 800 is over 5 times that, maybe this is sort of a lost cause. Maybe I shouldn't even be trying to look at creating a cohesive group. And when I look at you all, I realize that, yes, we are very divided in many ways. We each have divisions that we belong to. But then even when those divisions, there are divisions within those divisions. So if you just take general internal medicine, you got the people that are the hospitalists, the people that are the outpatient people, the palliative care people. I can go to GI, I can go to cardiology, I can go to my own division, and I can see the same thing. We have subdivided amongst ourselves. We have MDs, we have PhDs. We have inpatient, we have outpatient. We've got people that work at the VA, we've got people that work at Jewish Hospital. There are just the number of divisions, and the way that we can slice and dice ourselves is incredible. A gazillion different permutations of who we are. So how could I even hope or think that I could gather everybody together in a single cohesive group? So before despair totally set in, I suddenly thought to myself, wait a minute. Think about a football stadium. You don't have just 150 people there, rooting for a team. You've got thousands of people. You have thousands of people all united around a single project. We want our team to win. Of course, they do the same thing in war. You've got an entire group of people that's saying, kill the other guys. There's some similarity there, but, it's a matter of degree, So it occurred to me then that although maybe, the 150 is good for some social situations, that if there is a single important goal, something that people can rally around, that number gets to be much larger than 150. And I thought to myself, not only that, but I actually have an example of that in my own work. Which brings me to the third thing that I love, which is working at the VA hospital. Now, for those of you who don't work at the VA, haven't been there in 15 or 20 years or whatever, you may think that I am crazy. I may be anyway. However, the reason that I like to work at the VA, one of the major reasons, besides the fact that I like working with veterans, is that you can walk around that hospital and you can snag anybody that works there and say, ask them, why are you here? And that person will say, I am here for the veteran. My job is to help the veteran. There is an incredible sense of shared purpose at the VA. And this, I want you to know, did not happen by accident. I feel like I have been witness to one of the most major transformations in a healthcare system that has ever occurred. And make no mistake, the VA is the largest healthcare system in this country. And when I was in training, and for those of you who are as old as I am and were in training at the VA, you guys remember the fractured VAs that we went to, charts all over the places, patients wandering around, no sense of anything. 20, 25 years ago or so, the VA decided that they were going to do something that every single other medical system now is espousing but has not achieved. And that is they were going to become patient-centric. The first thing they did was to reorganize the veterans into groups that each were assigned a single primary care provider. So no longer would a veteran just, walk up to the desk and say, hey, I need an appointment with neuro. Hey, I need an appointment for somebody to look at my foot. They had a primary care provider who was the person who orchestrated their entire care. The next thing that the VA did is they instituted an electronic health system such that that primary care provider could figure out what was going on with that patient at any time. They went to this guy, what did that guy say? What medications are they on right now? And they, more than anybody else that I've seen, developed a team system in which a physician was a part of the team, but the physician was not necessarily the leader of the team. Now, I don't mind telling you guys that this was painful. This was extraordinarily painful, and I had some colleagues that actually decided to resign from the VA because they said, the VA doesn't care about me anymore. I'm a doctor, and they don't care about doctors. And for those of us who remember when the physician was the center of the healthcare galaxy and everything revolved around us, it was painful. It was painful to be part of a process where that was no longer the case. And I think we all know that. That is no longer the case. Are we important? Yes, we're very important. We're a critical part of the healthcare team, but we are no longer the center of the universe when it comes to healthcare. Now, I said for some colleagues that this was so painful that it was not something they could tolerate and they left. But I'll have to say, for me, I actually found this strangely comforting and in a way empowering. I felt like I was part of something that was much bigger than just me. What I was doing was something that was much more important because it was part of a big purpose. I was helping to take care of veterans. And I was doing that with the help of my nurses, my nurse practitioners, et cetera, et cetera. So there is a sense of cohesiveness there. There is a sense of shared purpose. It is an example where you can bring together people that do all kinds of different things and have all kinds of different interests working towards the same goal. So why do we not feel like that, or why do I not feel like this down here? Why don't I say, what are we here for? And I can pick up anybody and say, they're going to say, I am for blank, because that doesn't really exist down here. Now, some of that is definitely a function of the fact that academic medical centers characteristically will insist that individuals distinguish themselves by their personal achievements, this is how you go for promotion. It's hard to get promoted if all you do is help other people all the time. You get promoted if you write your grant, you get your papers published, you start your program. So the culture within an academic medical center is to promote the self and to promote the self above the collective. Now, this is not to say, and I don't want anybody walking out of here saying, God, Dr. Lederer said every single one of us is selfish. No, not at all. Not at all. I mean, I'm looking at a group of people that have devoted themselves in one way or another to treating patients, to helping maintain health care. But I would submit to you that we have not harnessed the collective spirit, the collective will, the collective strength of this group of individuals, which is you guys, the Department of Medicine. And it's going to take a big effort to do that. Now, this has also, if we look at how we've gotten into the situation that we are right now in our own healthcare system, this has played out there too. And for this is my last story that I'm going to tell this morning. But it was an important lesson that I learned probably 20 years ago. Dick may actually remember this. Okay, I'd just become training program director. And I'd always been puzzled and maybe like a little bit irritated because Jewish Hospital would never support our fellows. We didn't get a cent from Jewish Hospital to support our fellows, and yet we had a big service over there. I had a fellow over there all the time. And so when I went to the graduate medical education office and I said, why aren't they giving us a fellow? Why won't they pay for a fellow? And they said, well, you can go over there and ask them. So I did that. Made my appointment, went over and talked to Doug Shaw, sat in his office, made my pitch. I said, you know, we are good for Jewish Hospital. We're loyal to Jewish Hospital. We've been here forever. You know, why can't you give us a fellow? And although he probably gave me 1,000 clues, I just missed them all. But he said, you know, we have limited resources. We are already committed to funding several trainees. I guess we could rearrange things, you know, a bit, you know, if somebody's not using a spot, you know, to come to Jewish Hospital. So I walked out of that meeting, master negotiator. I got, you know, 2 fellows funded, et cetera, et cetera. That was in the morning. I think it was like about 3 hours later. I got a call to come see Dr. Redinger. And I was thinking to myself, I'm going to be congratulated, you know, on the job that I've done. I'm walking there, and Dick goes, you know, I just got a call from the chief of pulmonary. You know, he wants to know why his fellowship support has been pulled. So, you know, of course, the whole story came out. We didn't get any fellowship support from Jewish Hospital, and that went back to where it came from. And the lesson that I learned then, at that time, in that very minute, was, wow, you know, before you do something big and make a big decision and make a huge change, you really need to figure out what the impact is going to be on everybody else that could potentially be affected. But I learned another lesson. I didn't realize it at the time, but I do now. And that lesson that I learned is that in our dealings with the hospitals that we work with, everything is one-off. If I want something, I go to the VA and try to negotiate it for it. If he wants something, he goes to UofL Hospital. Sometimes the person going there will be the department chair. Sometimes the division chief. Sometimes the training program director. When you think about it, is this a good way to develop a mutually beneficial healthcare system? And I would submit to you, no, it's not. It's not. Many times, my very good friend and colleague, Chip Jacobs, would say to me, why why isn't somebody way far up in the administrative ladder getting together with the top administration of Jewish Hospital and actually developing a full-fledged transplant program? Not a little piece here, a little piece there, but the whole works, the whole works. Now, in all fairness to the people that have come before me, for all I know, they tried, and they tried, and they tried, and maybe just failed to make any headway. But the fact is that what that's left us with is an extraordinarily fragmented system where each of us is going on our own. I won't say not really caring what happens to the other person, but actually not really maybe thinking through, if I go to Jewish Hospital and I get this, whatever it is that I want, how is that going to affect cardiology? How is that going to affect transplant surgery? How is that going to affect anybody else at all? I suspect from the hospital standpoint, they probably thought this was a pretty good deal. They could pick and choose what they wanted. They could just deal with one at a time. You know, they could ditch what they didn't want, etc. Perhaps we thought this was a good deal too. Hey man, I can get in there and I can get my fellows and I don't care what happens to pulmonary. But I would submit to you also, looking at things now, it may have seemed like a good deal for everybody then, but does it now? We've got a hospital that is on the verge of collapse. We have programs that are endangered. And it really didn't have to be like that. It really didn't have to be like that. So, I come back to what I wanted to be my goal in being the interim chair, which is to develop that sense of a cohesive unit. Every single one of us here is working for the mission of safeguarding the health for all of the citizens of Louisville and the surrounding area. Some of us are doing it by seeing patients directly. Some of us are doing it by training individuals to be researchers or doctors or excellent nurses. Some of us are doing it by being in the lab and discovering new drugs, new therapies, new mechanisms of disease. I don't know exactly how to go about uniting this group into a whole, except to say that each one of us, because I can't do it by myself. I can't get up here and say, now we're all one big happy unit. It's going to require every single one of us to look at our neighbor and say, you know what? What that person does is really important. And it's just as important as what I do. It's also important to be able to look at that neighbor and say, I know that guy has my back. This person will be looking out for me as much as I will be looking out for them. So going forward, what I would like is for us to start thinking as a collective, working as a collective, and planning as a collective. And I challenge every single one of you to step up to the plate and become literally a part of the solution. Welcome to Grand Rounds. I think Jesse was right. This one meeting once a week for an hour can be a tool to use for cohesiveness. I look forward to the coming year. Thank you all very much.